Great.
So we're going to cover hydroxychloroquine toxicity. Hydroxychloroquine is also known as Plaquenil. And we are screening patients for hydroxychloroquine toxicity. And the toxicity is a bullseye maculopathy. But basically, we never want to see the bullseye. We want to recognize the toxicity and stop the medicine before the development of the bullseye, because that is permanent damage to the retinal pigment epithelium and it can result in irreversible vision loss. The key things that we want to know in the screening strategy is how much risk are we dealing with? And the risk is determined by patient-related factors and then drug-related factors. The patient-related factors are age, and older patients, you should follow them more closely, 65 or older. Obesity and their weight, even though that's being de-emphasized now. Their renal function and their liver function, because that's how the drug is excreted. And then we want to talk about factors that are related to the drug. The drug-related factors are the dose, and in the older literature, 6.5 milligrams per kilogram was considered the risk threshold, but then you had to adjust for the weight and ideal body mass, and so now we just say 5 milligrams per kilogram is kind of our new threshold dose. We want to know the duration, and the longer you've been on it, the more likely you are to get the toxicity, and the cumulative dose, which is 1 kilogram of drug. So if we've been on the drug for longer than 5 years, we are already starting to think about toxicity. The toxicity rarely occurs before 5 years. And so really, we shouldn't really be worried about it until year 5, but you're going to screen the patient more aggressively after 5 years, and after 10 years to 15 years, your risk is going up a lot. So it's kind of becoming a linear risk, and by 20 years, maybe up to 20% of the people are going to have risk of toxicity. So dose and duration, cumulative dose are all super important. We'd like to know if you had previous macular disease, so I tend to recommend against hydroxychloroquine in patients who have pre-existing maculopathy, like age-related macular degeneration, or who can't do the tests, like kids or really old people. And if they're on any other drugs, but especially tamoxifen, that's a really dangerous thing. And you need to know that Asian people are more likely to have a periaxial form of the disease, a peripheral form. And so even though we recommend doing a 10-2 visual field for screening, we might do a combination of a 24 and a 10-2 in an Asian patient because they're more likely to have peripheral field loss. The screening strategies, once you've decided someone is a high-risk patient, is we have to do tests. So yes, we're going to talk to the patient and ask them about their vision, but the tests we're going to do are the Humphrey visual field, and we're going to be testing the central field. So we want a 10-2 and not a 24-2, unless they're the Asian patient. We want to do an OCT, and we want to do a spectral domain OCT of the macula, and not a time domain OCT. So this side is the yes side, and this side is the no side. We want to do a multifocal ERG if we have it, but we don't really want to have a full field ERG because that's not as good. We're going to do fundus autofluorescence, and we're not going to do a fluorescein angiogram. It is the combination of these tests that is how we screen patients. And so normally you need a field of some kind. We give patients an Amsler to take home, but we don't use that in the clinic. We use the 10-2. We're going to do a spectral domain OCT of their macula. And we're going to do an MERG or a fundus autofluorescence. So a field plus one of these three is probably reasonable. You don't have to do all three, but you have to do something. And we're going to not do the 24-2, the time domain OCT, a full field ERG, a fluorescein for screening. The rest of the exam is like a normal eye exam for patients who are on hydroxychloroquine. So in summary, in patients who are on hydroxychloroquine, we need to make a risk stratification, but the highest predictors of risk are dose, duration, cumulative dose, and whether they have concomitant renal and liver dysfunction. Once you're starting to get over a kilo of cumulative dose, above 6.5 mg per kg, or duration greater than 5 years, you really should be considering that person a higher risk. You should worry if they're on concomitant tamoxifen, if they have pre-existing macular disease, and you have to have a slightly different strategy for Asians 24 versus 10-2. You have to do a field, a 10-2, but not a 24-2, an OCT spectral domain of the macula, but not a time domain OCT, MERG, but not a full field ERG, and a fundus autofluorescence, but not a fluorescein angiogram. You need to do a field plus something else. I usually use OCT. And if you do that, we can prevent the patient from having a bullseye maculopathy and hydroxychloroquine toxicity.